One. Sir, please start. We are live now.
Good evening, all. Good evening, sir. Today we are having a clinical conversation on Nuvega. It's a prostate cancer update CME. And today we are having two speakers with us. One is Dr. Shuman Meur. He's a consultant medical oncologist at BR Hospital as well as Shortgupta Cancer Hospital. So today, sir will speak on the reaching new heights in MHSPC care. If sir is ready now, over to sir.
Thank you, Arnav.
Thank you.
I'll start. I'm sharing my slides from my laptop.
Oh.
So I think my slides are visible.
Yes, absolutely.
So we'll discuss tonight about the metastatic hormone-sensitive prostate cancer. And my apologies first because I'm not much acquainted with the slides tonight, and it might be a bumpy ride. So to start with, slides are not changing. Yes. So let us discuss the natural history of prostate cancer. Mostly we start with a localized or locally advanced prostate cancer, and they usually progress with time through a biochemical recurrence or through a disease progression into two groups: a primary progressive metastatic hormone-sensitive prostate cancer or a non-metastatic castration-resistant prostate cancer. And even if the patient is on ADT, we can see the patient worsen into these two subgroups. And most of the cases we find the patients to be diagnosed with a newly found metastatic hormone-sensitive prostate cancer who are usually started on ADT. And at last, if the patients do not respond or show some disease progression, they end up into metastatic castration-resistant prostate cancer. And this is the point where the disease becomes deadly, and at the terminal point of the disease, death is inevitable. So our goal is to prevent this state where we shouldn't reach up to this state of metastatic castration-resistant prostate cancer. When we find a patient with prostate cancer in metastatic state or non-metastatic state, we need to prevent it in that very stage, so that we can prevent most of the deaths from metastatic CRPC, where the OS improvement of all treatment is only 2.5 to 4.5 months. So we'll discuss today about the metastatic hormone-sensitive prostate cancers. It might be a newly diagnosed one or a primary progressive one who is already getting ADT, and the PSA, the testosterone has not reached the castration level yet, but the disease has been progressed in form of increased PSA or in form of local disease progression. So the opportunity here to treat is again to delay the metastatic CRPC stage and further improve the outcomes in form of disease control and overall survival. So our standard of care treatment initially was ADT, and then after the era of charted and stampede trials, we could add docetaxel with ADT to have a better outcome, to have overall failure-free survival and overall survival. But right now we can do much better than that. In stampede trial, we not only have added the chemotherapy in form of docetaxel, but also we had an opportunity to offer radiotherapy to the low disease burden patients. And what we can see that in patients with less than 4 bone metastasis, the hazard ratio is quite impressive. It is statistically significant also for failure-free survival, and for OS, it is also statistically significant. But if the disease is bulky, it is there are more than 4 bone metastases or there are visceral metastases, then the hazard ratio still is statistically significant, but is not that much impressive. We can see in the Kaplan-Meier curve, the both survival curves are not separating that much, and also for the OS. So in bulky disease, the STAMPEDE trial is not that much impressive. So this is a timeline of the other agents that we have used to treat an advanced prostate cancer over the time. After the publication of CHARTED trial in 2015, and in 2016 and 17, the STAMPEDE, two different arms with docetaxel and abiraterone acetate. We had opportunity to add abiraterone in through the Latitude trial. We had experience of adding enzalutamide in Arches trial, apalutamide in Titan trial, enzalutamide again in Enzamed trial, and the PEACE protocol. We'll discuss this later on in details. And lastly, in 2022, the Arasens trial, where we have added darolutamide with docetaxel along with the ADT standard of care. So first, let us discuss the CHARTED trial. Here we can see adding docetaxel to ADT versus ADT alone had better overall survival. And it was statistically very significant. The hazard ratio was 0.63, that is almost a 37% reduction of the risk. And improvement of WACE was 16.8 months. For low volume disease, actually, it was not that much effective. We can see the p-value is 0.86 and the hazard ratio is actually 1.04, which is more hazardous since the side effects of docetaxel. In Latitude trial, adding abiraterone acetate actually this gave us this explored new opportunity to offer a better treatment without chemotherapy along with ADT. We can see that abiraterone showed very good survival benefit in the patients who are already having a progressing disease. The overall survival here is very statistically significant. The hazard ratio was 0.66. The main adverse reaction of abiraterone was through its mineralocorticoid related adverse reactions, that is hypertension, hypokalemia, and also some hepatotoxicity from abiraterone itself. Prednisolone, 5 milligram twice a day, was added in the trial, and it actually reduced the adverse reactions in modest quantity. And still, we can see that in the trial, grade 3 hypertension was quite a bit. 22 patients were there, and hypokalemia was also observed in 11 of the patients. And in the placebo group, the incidence of these side effects are really less. Even if the patients are crossed over from placebo to abiraterone, they are showing some side effects, though in less frequency. Next, in apalutamide, the Titan trial compared this drug with placebo along with usage of ADT, and we can see very good progression-free survival with hazard ratio of 0.48, which is very impressive. But we can see that in low volume patients, the PFS is this much impressive, but in high volume patients, the hazard ratio is increased. It is 0.53. So I think apalutamide will work better in low volume disease patients only. OS was also statistically significant with a hazard ratio of 0.65. In Enzamet trial, they have compared this drug with non-steroidal anti-androgen drugs, and they found the hazard ratio to be again very impressive, 0.4, with overall survival of 0.67, both being statistically significant. And again, we can see that this drug is actually very effective in the low volume patients only with hazard ratio of 0.43, but in high volume patients, it becomes the hazard ratio becomes 0.8. It doesn't become that much impressive and also not statistically significant. Now came the era, the researchers and the clinicians thought that how we can improve on the bulky diseases, how we can add another drug so that we can control the bulky diseases more. Then came the peace protocol. The journey of the peace protocol trial, peace study, was not very smooth. Initially, they took ADT to be the standard of care in the comparator arm, but with advent of docetaxel along with ADT, they changed the standard of care to become the dual usage of ADT and docetaxel, and they compared it with the addition of abiraterone or not. They also offered radiotherapy randomly to some patients. We can see in arm C and arm D that they offer radiotherapy to randomly selected patients to see whether addition of radiotherapy is beneficial to these patients or not. The peace study found that in high volume disease, addition of abiraterone along with docetaxel, that is the triple therapy, is very much effective. The high volume disease is usually defined as a disease with more than 4 bony metastases with at least 1 extraaxial bony mets or any visceral metastasis. And in these patients, we can see that this triple drug regimen has a good hazard ratio of survival. It is around 0.72, which is statistically significant, but it is not in the level of less than 0.001. It is 0.019. So I think the separation of these curves itself shows that in later on, when the most of the patients are failing after 2 to 3 years, here we can see the effectiveness of Peace 1 protocol. But again, when we see the effectiveness of Peace 1 protocol over low volume disease, we can see that the hazard ratio becomes insignificant. It becomes 0.83 and the survival benefit is lost. Now let us come to the Arasen study. As we can see that other androgen receptor pathway inhibitors, they are very effective on low volume disease, and Peace 1 protocol are actually beneficial for the high volume disease. We actually needed to make up this gap to have at least some medicine that will be effective for both of these subgroups. In the Arasen study, darolutamide was added along with docetaxel and ADT to the patients who are having metastatic hormone-sensitive prostate cancer with ECOG PS 1 or 0, and the patient was able to take docetaxel and ADT. The patient should be at least fit, and no, there should be no contraindication of giving docetaxel to these patients. The primary endpoint was overall survival, and they also had many secondary endpoints in form of time to castration-resistant prostate cancer, time to pain progression, etc. And we can see that 87% of the patients in this study arm had all the 6 cycles of docetaxel. They could complete all the 6 cycles. And the adverse events between the 2 arms, in one arm, ADT, docetaxel, and placebo was used. In the other arm, darolutamide was added instead of placebo. Both of these arms had very similar adverse reactions. So what was the outcome? In overall population, we can see the hazard ratio of survival was statistically significant in terms of 0.68, which is the p-value is less than 0.001, which is statistically very significant. For high-risk patients, though the hazard ratio is a bit increased, it is still statistically significant. And for low-risk patient, again, it is statistically significant with hazard ratio of 0.62. So we can see that Erasmus trial actually gave us that weapon which can be used universally to the high risk or low risk patients. Again, the secondary endpoints, time to progression into CRPC, and we have discussed that this is very important because if the patient progresses into CRPC, then the overall survival diminishes very fast. We can see that even after 54 months, more than 50% of the patients who are having darolutamide has not progressed into CRPC, and the median survival has not yet been reached. Whereas in the placebo group, ADT and docetaxel only, the patient's median survival, CRPC free survival, that means time to progress to CRPC is 19.1 months, which is not that much impressive. And here we can see the hazard ratio is extremely good, 0.36. 64% risk reduction has been done with adding darolutamide with docetaxel and ADT. Time to pain progression is also statistically significant. We can see 21% risk reduction. Time to first subsequent antineoplastic therapy, it is also been has been shown to be very impressive at 54 months. The median has not yet been reached, and 61% risk reduction has been done. Time to first skeletal events, symptomatic skeletal events, we can see that both of the arms did well, but darolutamide arm yet has done better with 29% risk reduction with a statistically significant outcome. Now we can see with adding darolutamide, 48.7% has reached undetectable PSA in 24 weeks, and in 36 weeks, which is a standard, we can see 57.1% has reached an undetectable level of PSA, whereas in the placebo arm, it is only the half. Time to PSA progression, we can see the result is very much impressive over 54 to 57 months. Most of the patients, more than 80% of the patients are keeping with undetectable PSA levels, who has already reached undetectable PSA level, whereas the detectable PSA as 36 weeks, the median, though has not been reached, is very much low with hazard ratio of 0.23. And the OS benefit is still good for the undetectable PSA level cohort, which is very much higher than that of the detectable PSA, with hazard ratio of 0.37. More than 2/3 of the patients reached below 0.2 in overall study. So this is very impressive. This is very impressive because less than 0.2 is actually ultra low PSA. If the patient attains this level, then the chances of disease progression or become a castration-resistant prostate cancer becomes very low. In high volume diseases, we can see that at 36 weeks, 51.3% of them has reached undetectable PSA, whereas in the placebo group, 22.4% only has reached this level of PSA. And we can see for these two subgroups, the time to PSA progression has this is actually highly different, highly significantly different, with hazard ratio of 0.2 only, 80% reduction of risk of PSA progression in the undetectable PSA group. And OS benefit with darolutamide in these groups are also very prominent, with hazard ratio of 0.3 only. So darolutamide triplet achieved a long periods of no disease progression and also significant improvements to overall survival. In low volume disease, the results are also very impressive. and 36 weeks, undetectable PSA levels have been reached by 76% of the patient, whereas in the placebo group, only 34% of the patients has reached this level. And we can see the very widening fork of the Kaplan-Meier curves, survival curves of these two groups. In a darolutamide group, the time to PSA progression is very impressive, and the hazard ratio is hoping 0.09, that is 91% risk reduction in this group. And the OS benefit is also very high for the low volume disease as well. So as we can see that adding darolutamide as in form of the triplet therapy, the Erasmus trial gave us benefit in all forms, but we need to decide where to give doublet and where to give triplet therapy in metastatic hormone-sensitive prostate cancer. The things that we need to consider firstly is to whether the patient is fit and can accept or tolerate docetaxel at all, because we need to complete the 6 cycles of docetaxel in most of the patients. We need to assess the volume or extent of the risk, and whether there is high likelihood of hormone insensitive clones. Patient's age and life expectancy is also very important in choosing a drug, because we need to hit hard and early, where prostate cancer shouldn't cause death for a long time, because we need to keep the PSA levels very low for a very long time, so that the disease burden also should reduce, so that we can prevent the progression into castration-resistant prostate cancer. So another question is that whether docetaxel will be an obligation for the near future, obligation in the near future for these patients, because if the patient has progressed after androgen receptor pathway inhibitor, in future the in CRPC patients, they do not respond well to docetaxel. So sometimes we feel that we need to keep docetaxel in reserve for using it in future, but the logic is to use it early, because we need to achieve the best of the PSA response and best of the disease response, so that the patient survival becomes durable and best longest possible. And also patient's information and shared decision making is very important. So with this, I conclude my session tonight. If there is any question, can shoot me.
Thank you, sir, for your wonderful presentation. And we will definitely take any questions at the end of our meeting. And now I would like to request our next speaker for tonight, Dr. Vivek Agarwal, Senior Medical Oncologist at Narayana Super Speciality Hospital.
Yeah, a very good evening to all of you. And I would request Arnab to kindly share the slides.
Sure, sir.
Thanks to Bear for giving me this opportunity. And I think Dr. Suman Mayur has done a very fantastic job, talking us through the metastatic hormone-sensitive prostate cancer landscape, as well as the Harrison's data, embarking upon the use of triplet with androgen receptor pathway inhibitors. So we all know that in metastatic hormone-sensitive prostate cancer, over the ages, we have quite advanced ourselves. Next slide. From the age of ADT only to adding docetaxel upfront with ADT. Go back to the previous slide. ADT along with the docetaxel, as well as the first androgen receptor pathway, inhibitor, abiraterone, along with the ADT. And along with that, the androgen blockers also came into the picture in the metastatic hormone sensitive prostate cancer space, with enzalutamide along with ADT being there in the ARCHES study, apalutamide with ADT coming in the TITAN study. Enzamet also, sort of showed how enzalutamide can be used in some of the patients where they have been given docetaxel as well. And finally, in the last 5 years, now we are already using the triplet therapy with either abiraterone or darolutamide being added to docetaxel plus androgen deprivation therapy as per the PEACE-1 or the ARASEN study. Now, one lacunae that remains for darolutamide is that darolutamide with the Arasens probably showed the best safety profile along with the efficacy when it is combined with the ADT and docetaxel. But if you want to use darolutamide and not want to use docetaxel in any patient of metastatic hormone sensitive prostate cancer, for whatsoever reason, because the patient is not wanting to, take chemotherapy or denies chemotherapy, or patient is not fit enough for chemotherapy, or the patient is not a very high risk, high volume prostate cancer, and you want to treat them with androgen receptor pathway inhibitors only, then the choices as per the clinical trials remain of combining ADT with either abiraterone or enzalutamide or apalutamide, and the choice of darolutamide, despite it being such a safe and such a wonderful drug, was not there, and that is where the lacuna is filled by the ARANOTE data, where darolutamide with ADT was used in metastatic hormone sensitive prostate cancer without docetaxel. So that is how this study has further widened our armamentarium and options in metastatic hormone sensitive prostate cancer. Next slide. So just as I said that in metastatic hormone sensitive prostate cancer, it would be probably now unfair to say that it is remaining an unmet medical need, because there are now ample treatment options available, both intravenous or oral, to use. However, still, when we are looking at the oral options with ADT, uh, there is a a potential drug-drug interaction that can take place with the other androgen receptor pathway inhibitors like abiraterone. We face toxicity concerns of concomitant steroid use, of having pedal edema, of having fluid overload, long-term bone loss associated with steroid use, which are concerns. And with apalutamide and enzalutamide, there is definite concerns about higher, fatigue, of seizures, of falls and fractures, of more, cardiac effects being hypertension and arrhythmias, potential drug interactions, rashes, and so on and so forth. And with this, the ARANOTE data now gives us the option of using darolutamide, which has a better safety profile than any of the androgen receptor pathway inhibitors, and we can use the darolutamide now with the androgen deprivation therapy in metastatic hormone sensitive prostate cancer, even without chemotherapy, also in our patients. Next slide. So now darolutamide plus ADT has become a standard of care, and ARANOTE is the study which is evaluated this darolutamide plus ADT versus ADT to provide a new treatment option without docetaxel. Next slide. So this was the ARANOTE study design. So it was a randomized double-blind placebo-controlled phase 3 study, and it included around 660 patients of metastatic hormone sensitive prostate cancers who were treatment naive. These patients, they were histologically confirmed to be prostate adenocarcinoma having a PS of 0 to 2, and they had allowed patients to have either high volume disease or low volume disease, but they had stratified patients whether they had visceral metastasis or not, and whether they had received any prior local therapy or not. Patients were randomized 2:1, received dialtomide 600 milligram twice daily with ADT versus placebo plus ADT. And the primary endpoint was radiographic progression-free survival, which is now quite an accepted surrogate endpoint for overall survival, giving us earlier results so that these treatments could be incorporated earlier into the guidelines. However, OS still remains a key secondary endpoint. Other secondary endpoints include time to initiation of subsequent antineoplastic treatment, time to CRPC, time to PSA progression, rates of undetectable PSA, that is, low PSA less than zero point 0.2, as well as ultra low PSA less than 0.02, time to pain progression, as well as safety. And other pre-specified endpoints were PFS2, time to skeletal system skeletal events, time to deterioration of quality of life scores, and time to first prostate cancer related invasive procedure. So this was actually an open label darolutamide study until the final analysis, and there was a 100% crossover to the open label darolutamide, so that uh, you know the patients who were in the not in the placebo arm were subsequently given darolutamide on progression based on the selected endpoints of OS and safety. Uh, the data cutoff was in June 2024, and the median follow-up in the darolutamide as well as the placebo group was more than 25 months. Next slide. So these are the patient demography and clinical characteristics at baseline, and what we can starkly see that there were almost 30% Asian patients that were included in this study, and this is of course relevant because there were nearly around 13% Indian patients in this study, and we can definitely extrapolate this data to Indian patients also very easily because a significant number of them were Indians. If you look at the PS distribution, they were PS 0 or PS 1 to 50%. The Gleason score was 8 or more in almost 70% of the patients, and the median serum PSA at baseline was more than 20 in both the arms. If you look at the presence of metastasis at initial diagnosis, it was 70% patients, whereas nearly 22-23% patients were actually recurrent disease. And if you look at the volume of the disease, so surprisingly, 70% of the patients, they were having high volume disease, but 30% were having low volume disease. So you can even apply this data to high volume disease patients also. If you look at visceral metastasis, almost 10 to 12% patients had visceral metastasis, and almost 17% patients had received prior local therapy. The baseline characteristics were quite equally distributed in both the arms, and there was no unequal distribution. Next slide. So this is the country representation across the breakthrough clinical trials for prostate cancer treatment. And what we can see is that Arrow note quite represents almost a global representation, including patients from almost everywhere around the world. So it represents probably a more uniformly selected patients with least bias as per the regions or race. Next slide. So as we can clearly see, almost 13% patients were from India, and rest of the other Asian patients were from the other Southeast Asian countries. So this is the primary endpoint result. And if you look at the radiographic progression-free survival at the end of 2 years, so we can clearly see that there is almost 18% difference and improvement in radiographic progression-free survival at 2 years from 52% to 70%, with the median radiographic progression-free survival not reached in the dialtomide arm, whereas this being almost 25 months in the placebo arm with a hazard of 0.54 and a significant p-value. Next slide. If you look at the subgroup analysis of radiographic PFS, so clearly all subgroups of patients seems to benefit with this combination of darolutamide plus ADT. And what you can clearly see that the hazard is the same as that of the primary intention to treat population, around 0.5, except in the patient who had more visceral metastasis. Those are the 10% patients where the median was actually seen to be crossing, the confidence intervals were seen to be crossing the median. And so clearly what we can understand is that those patients who have visceral metastasis probably are the ones where we must choose triplet treatment and add docetaxel early on, whereas rest all patients, even if we choose to give darolutamide plus ADT, they do not seem to be doing worse, and they seem to be doing good also. Next slide. Look at the high volume on the low volume disease. Again, the subgroup analysis clearly shows that the benefit was there in both high volume as well as low volume disease. To look at the other endpoints like time to metastatic CRPC, time to PSA progression, time to pain progression, time to initiation of subsequent systemic therapy, all of them were significant and favored darolutamide arm. The OS endpoint was premature at the time of the analysis, and therefore we cannot make out much from the OS data. Next slide. So this is the time to metastatic CRPC, and again we can clearly see the curves being separate and with a hazard of 0.4, the data clearly favoring darolutamide as compared to the placebo. Time to pain progression was also better with darolutamide plus ADT with a hazard of 0.72. Next slide. If you look at durable and deep PSA response, now mind you, in metastatic hormone sensitive prostate cancer, if you're able to achieve a PSA which is less than 0.2, it is a very, very important and good surrogate endpoint for long term good outcomes and better overall survival. And almost 63% of the patients in the darolutamide doublet arm attained low PSA less than 0.2, which represents a 69% improvement in the time to PSA progression darolutamide arm as compared to the ADT alone. So clearly, if you look at deep PSA responses as well as the time to PSA response, we clearly see both are much, much better in the darolutamide arm as compared to the placebo. Next slide. Also, what you can clearly see from this data is that there are a higher proportion of patients achieved undetectable PSA with darolutamide versus placebo in both high volume as well as low volume subgroups. And if you look at the different time points, you can clearly see that by almost 6 months, 24 weeks, almost 50% patients were able to have undetectable PSA that is less than 0.2, and almost by the end of 1 year, it seems to be plateauing. And in low volume disease, this was almost 80% at the end of 1 year. So at the end of 6 months, almost 70% achieved undetectable PSA, which increased to almost 80% by the end of. Next slide. Also, if you look at the patients who received the subsequent systemic therapy, so 30% patients, almost 32% patients required next line of systemic therapy in the darolutamide arm as compared to 42% patients in the placebo arm. If you look at the different systemic treatment that were given, so docetaxel was used in as a next line of treatment, almost 22% patients, whereby this was given in almost 28% patients. Abiraterone was given to almost 13% patients, both the arms, and enzalutamide was slightly higher, 7.5% in the placebo arm. So both the arms, almost nearly 50% patients received subsequent treatment, and the placebo arm also, received almost 80% patients received subsequent treatment, which quite says that the data is more robust, as the placebo arm did go on to receive significant treatment after progression. Next slide. Now, if you look at the treatment emergent adverse events, these were very similar between the treatment groups, and discontinuations were in fact lower in the diazotamide arm. So, if you look at the grade 3 adverse events, they were 30% around in both the arms, and serious adverse events were around 23% in both the arms, which clearly tells you that there are hardly any toxicities of diazotamide beyond ADT, and this is quite remarkable, quite in line with the Aramis and the Aracels data, and quite tells you a lot about the safety of diazotamide as compared to the other androgen receptor pathway inhibitors. Next slide. Now, if you look at the rates of most common adverse events, and fatigue is something that is quite, sort of associated with androgen receptor pathway inhibitors, you see that only 5% patients had fatigue, which was almost 8% in the, placebo arm, and grade 3, grade 4 fatigue was zero with the diazotamide. Also, if you look at other side effects like hypertension, like bone pains, like hot flushes, uh, like back pain, like arthralgia, all of them were same in both the arms. There are absolutely no side effects which was higher with the diazotamide as compared to the placebo. And again, it quite stresses that the adverse events with diazotamide are low and very similar to that of the placebo and the ADT. Next slide. Now, if you look at the rates of adverse events associated with ARPIs, like hypertension, like vasodilatation, rashes, and flushing, like metabolic disorders like diabetes, hyperglycemia, cardiac arrhythmia, rashes. Again, everything looks to be very similar with diazotamide as compared to the placebo. Next slide. If you look at the quality of life data, now this also clearly shows a favorable quality of life scoring and time to deterioration of the quality of life scores as compared to the placebo. So diazotamide clearly extended the median time to deterioration of the quality of life total score by 5.1 months, and this is the first and only AR inhibitor to actually demonstrate clinically meaningful delay in pain progression as well as the overall well-being. So this quality of life data is also quite important to note that the benefits are real and the side effects are actually very less, so that the quality of life of the patients actually improve a lot. Next slide. These are the clinically meaningful quality of life endpoints, that is the social or family well-being, emotional well-being, functional well-being, prostate cancer related symptoms, bowel symptoms, urinary symptoms. And if you look at all the individual components of the FACT-P subscale, you clearly see that in all the scales, in all the domains of quality of life, it all favors darolutamide as compared to the placebo. Next slide. So we can clearly conclude based on this ARANOTE data that darolutamide plus ADT significantly improved the primary endpoint, that is radiographic progression-free survival in patients with metastatic hormone-sensitive prostate cancer. Darolutamide showed a benefit across all secondary endpoints. Uh, it was associated with a deep PSA response regardless of the baseline PSA, regardless of the high volume or low volume disease. and it is the first and the only AR inhibitor to demonstrate clinically meaningful delays in pain progression as well as the overall well-being, including social or family well-being, functional well-being, urinary symptoms. And what is most remarkable about this data is that it has shown a very good and favorable safety profile, something that clearly sets it apart from other androgen pathway inhibitors. So now, based on the error node data, in patients where you are not planning to use docetaxel or you cannot use docetaxel because of whatsoever reason in metastatic hormone sensitive prostate cancer, darolutamide plus ADT is also a additional standard of care and a preferred standard of care for metastatic hormone sensitive prostate cancer as compared to the different androgen receptor pathway inhibitors plus ADT because of its starkly safe profile, as well as its equally good efficacy endpoints and action. So with this, I thank all of you for giving me this opportunity and for patient listening. And if there are any questions, I'd be happy to address them. Thank you.
Thank you, sir. Thank you for your wonderful presentation. Now, if there is any question, we can take the question. Sir, I think there is no question from the panelists, so we can conclude our meeting. Thank you for your wonderful time, sir. Good night.
Thank you. Good night.
Yes, sir. Thanks. Thanks all the attendees.
Sir, shall I close the meeting?